Hello, my friends. It's Dr. Sharon with Clinic Reviews. Today I'm doing an overview of labor and delivery. This is as fundamental as you can get about labor and delivery. There is more that we teach about as part of the Clinic Review, which is our on-demand Nclex review, but this is what you're going to find in the blue book right there that you can get on Amazon or get as part of the app. You can get it as an app through Clinic Reviews. So this is pretty fundamental. You got to know this stuff. So let's go ahead and get started. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. Today I'm doing an overview of labor and delivery. You know this YouTube channel is a part of the greater Clinic Review organization. You can do our Nclex review, do our streaming service, or do our small group tutoring. It is September. You may be watching this later, but at the beginning of every month, we restart our month of small group tutoring. So you can sign up now for our small group tutoring. And if this is a different month, you can sign up in that month for that month's small group tutoring. We do the same 4 sessions every month. So let's go ahead and get started. You know that I teach the content as we go through the questions most of the time, as opposed to doing a chunk of teaching at the beginning and then going through the questions. All of you, if you're here and you're getting ready to take NCLEX or you're thinking about taking NCLEX, all of you are in a nursing program or you have been in a nursing program. So I don't want to spend a lot of time teaching content that you've already had. This is more, the purpose of this is to remind you of content that you've already had, to make sure that you know content that you need to know to pass NCLEX or your standardized tests that you may have to take to get out of the program that you're in. So let's go ahead and get started. A pregnant client in her 3rd trimester reports feeling that it is easier to breathe, but she has to urinate more frequently. The nurse suspects that the fetus has dropped and that, sorry for the typo, and that lightning has occurred. Okay, so let me read that again. The nurse suspects that the uterus has dropped and that lightning has occurred. How long before labor begins does lightning usually occur? So this is just a vocabulary word. Do you know what lightning is? Lightning is when the baby drops lower in the abdomen. It pushes more on the bladder and the baby is getting ready for delivery by dropping down lower. So when does that usually happen? So either you know it or you don't know it. It's 2 to 3 weeks before delivery is when the lightning usually occurs. And it's okay for us to tell the patient that. Sounds like lightning has occurred and you're probably about 2 to 3 weeks out from delivering your baby. A client at 39 weeks of gestation comes to the obstetrician's office and is found to be fully effaced and 3 centimeters dilated. Which of the following signs most strongly suggests that the client is in true labor? So we say, well, they're fully effaced and they're 3 centimeters dilated. Are they in labor? Because she may say, well, am I in labor then? I mean, these are signs that she could be going into labor, right? So when do we say, yeah, we really do think you're in labor? Contractions decrease in intensity when walking, regular contractions, fetal movement increases, or Braxton Hicks contractions. So I know Braxton Hicks contractions is false labor. Fetal movement doesn't increase, just that's no indication of labor. Fetal movement might increase, but that doesn't have anything to do with she's gone into labor. Okay. So that has nothing to do with it. So would I expect contractions to decrease in intensity when walking, or would I expect her to be having regular contractions? So if she says to me, I'm having regular contractions, I'm going to say, looks like you've probably gone into labor. So regular contractions is the best indicator that they have actually gone into labor. If they have contractions that increase in intensity when walking, they may have gone into labor. Okay. So, but in this case, regular contractions is the best indicator that somebody has gone into labor. If she came in fully effaced and 3 centimeters dilated, but she was not having contractions, don't tell her she's gone into labor. Say, I bet you're going to go into labor really soon. Because if you're fully effaced, effacement is the thinning of the cervix, and dilation is the opening of it. But I wouldn't tell her she's gone into labor. You just go, you're really getting close there. You're going to be going into labor here really soon. And effacement usually occurs before dilation, just so you know. So it's not unusual to be effaced before you're dilated. A nurse is assessing a laboring client's cervix and notes that it is 50% effaced. What does this indicate? The cervix has shortened by half. The cervix is fully dilated. The baby's head is crowning. The cervix is dilated. So dilation and effacement are not the same thing. So I can cross out B and D. And effacement doesn't have anything to do with where the baby's head is at. So the only answer that makes any sense is the cervix has shortened by half. And I did put a picture here. I wanted to show you this because you may think, what? It's shortened. So here on the left, the cervix is not effaced or dilated. Okay, so you can see where the cervix is. And then the second picture, the cervix is 50% effaced and not dilated. So you can see that it's actually shortened. So when the cervix is 100% effaced and dilated 3 centimeters, you can see it starts to open more. So effacement is that shortening of it. But just so you know, the cervix is way thinner than that. When it's fully effaced, it's paper thin. So they can't really draw it paper thin, or you won't be able to see it. But it's paper thin when it's fully effaced. And then you can see there on the right, the cervix is fully dilated to 10 centimeters. Which of the following best describes what occurs during the third stage of labor? So we have 4 stages. Okay, 4 stages. The first stage is labor. The first stage is labor. And during labor, we have 3 phases. So we have 4 stages. The first stage is labor. The second stage is delivery of the baby. The third stage is delivery of the placenta. And the fourth stage is recovery. So which of the following best describes what occurs during the third stage? Well, which one is it? The cervix dilates, the fetus is delivered, the cervix effaces, the placenta is delivered. What is the third stage? It's delivery of the placenta. The second stage is delivery of the baby. The first stage is labor. And then we have the 3 phases of labor. So stages are the big ones. Phases are the smaller pieces of labor. During a vaginal examination, the nurse notes that the client's cervix is dilated to 7 centimeters. Which stage of labor is this client in? The first stage, latent phase, first stage, active phase, second stage, or third stage. Well, second stage is delivery of the baby, and she's still laboring, so that can't be it. The third stage is delivery of the placenta. She's still laboring, so that can't be it. So is she in the latent phase or the active phase? She's in the active phase. So 1 to 4 centimeters is latent, and it's called latent because there's a lot of time between contractions. So many women anymore are induced that a lot of women never really experience the latent phase. But if someone goes into labor naturally, the latent phase can last quite a while, can last hours. This is if a woman is doing a natural delivery or if she's delivering at home. This is the latent phase is when she's still walking around, probably still taking care of her kids. She's like, yeah, I'm definitely having regular contractions. They're happening every 10 minutes, maybe every 7 minutes. Honey, you can come home from work. I'm not going to be able to take care of the other kids for very long. Maybe she wakes her spouse up in the middle of the night, says, I'm having regular contractions, but it's not going to happen for a while. So this is the latent phase. And she's between 1 and 4 centimeters. And then 5 to 7 centimeters is active. So she's actively laboring. Her contractions are occurring every 3 to 5 minutes. And she's working hard. She's in a lot of pain. Once she hits 8 to 10 centimeters, that is the transition phase. She's transitioning from laboring to delivering the baby. So she's still in the first stage of labor, which is laboring, but she's transitioning. She's getting ready to move into that second stage of labor, which is delivery of the babies. But this at 7 centimeters, she's still in the active phase. How much blood is typically lost during a normal vaginal delivery? It's not measurable, 10 to 200, 100 to 200 mils, 300 to 500, or 800 to 1,000. So it's 300 to 500. So friends, you're not bleeding out. They're not hemorrhaging out when they deliver. This is all blood that's been part of the placenta and that's been part of the uterine wall, that's been providing blood and oxygen and nutrients to the baby, and that it's not needed anymore. So it's gotten rid of. Okay, so she's not hemorrhaging out. She's sloughing off the inner lining of the uterus, and she doesn't. You get the entire placenta. The entire placenta needs to be delivered, or they're going to be at risk for hemorrhage or infection. But there's still some lining left in there that will over time slough off, right? It takes several weeks, a lot of times for that to slough off. So she'll be having normal vaginal drainage for several weeks after delivery. During the latent phase of labor, what is the expected cervical dilation? 0 to 3 centimeters, 4 to 7 centimeters, 8 to 10 centimeters, 10 to 12 centimeters. Latent is that early phase where you're not feeling too much. So I said it was 1 to 4. Either way, you know it's not 4 to 7, right? Because 5, 6, 7 is definitely active. So you might go, well, Sharon, you told me the wrong number. Okay, use your common sense here. We know it's not any of the others. It has to be A. That's the only one that makes any sense because latent is the very earliest stage of labor and delivery. Which of the following occurs during the second stage of labor? It's not the phase, it's the second stage. So the first stage is labor. The second stage is delivery of the baby. Third is delivery of the placenta. And then the fourth is recovery. And so here we're in the second stage. So it has to be delivery of the baby or delivery of the fetus. During the transition phase of labor, so we're in the last phase of labor before we move into delivery of the baby. Okay, so now she's really working hard. She's in a lot of pain. She's probably saying, I'm never going to do this again. The client becomes very irritable. Yes, of course, and reports strong, frequent contractions. Yes, of course. What is the expected cervical dilation during this phase? 0 to 3, 4 to 7, 8 to 10, or fully dilated. Y'all, when they get fully dilated, once they hit fully dilated, it's time to push. Do not have them push before they are fully dilated. Okay, so they can push once they're fully dilated. And now they've transitioned into the second stage of labor and delivery, which is delivery of the baby. So in the transition phase of labor, they're still laboring. So that's 8 to 10 centimeters. Of the 4 women who are in labor, which of the following is most likely to deliver the baby first? A client who is actively laboring and is screaming and crying in pain. A client who is 9 centimeters dilated and says she feels like she needs to push. A multigravida who is 6 centimeters dilated and fully effaced. A client who is in the transitional phase of labor and states she feels like she needs to have a bowel movement. So I wanted to teach you that when they're in the transitional stage, and if they tell you they need to have a bowel movement, y'all, you pay attention. That's the baby's head pressing on the rectum. And very likely you take a peek there, you're going to see hair or the scalp or whatever, that baby's coming. So pay attention, okay? So if she's like in the latent phase and she says she has to have a bowel movement, maybe she needs to have a bowel movement. But if she's in the transitional phase and says, I feel like I have to have a bowel movement, you better expect that baby's coming. So what about the others? The others actively laboring, she's still in the second phase. She's going to have the baby, but just because she's in a lot of pain doesn't mean she's about to deliver. Someone who's 9 centimeters dilated, don't let them push until they're fully dilated. Okay, so she's probably going to have it soon, but she's not ready to push yet. Say, no, you can't push yet. A multigravida. Okay, so we go, but she's a multigravida. She can have the baby any minute. Well, she could, but we don't have evidence yet that she's about to deliver. We only know she's 6 centimeters and fully effaced. So yeah, she's actively laboring, but we don't have any evidence she's about to deliver. D is the person we have evidence she's about to deliver when she is in the transitional phase and she feels like she has to have a bowel movement. Leopold's maneuvers are used by the nurse to determine what during a labor assessment? The position and presentation of the fetus, the length of the cervix, the stage of labor, the frequency of contractions, just so that you know what a Leopold's maneuver is. It determines the position and presentation of the fetus. So the nurse, it's not something I can do, y'all. I'm not a labor and delivery nurse, but they can palpate the fetus and they determine where the head is and where the buttocks are and where the feet are. And they say, okay, they're in this position and this is, they're in the right position for delivery or they're not in the right position for delivery. Which of the following is the most important indicator of fetal well-being during labor? Fetal well-being during labor. Remember, you have 2 patients. You have mom and baby. You have to check on both of them. If they tell you something's going on with mom and they say, what should you do? Okay, what should you do? Usually you're going to say, let's see what's going on with baby before I decide what to do for mom. Usually, because I don't know what to do for mom until I know what's going on with baby first, right? This is what I'm talking about during labor and delivery. Okay, I'm not talking about recovery. But while we're still monitoring baby, like check and see what's going on with baby, okay? Before before you decide what to do. So what tells us how the baby's doing? So if I want to check on the baby, how do I do that? Well, I can't physically assess the baby. There's only one way I know how baby is doing, and that's looking at fetal heart rate and variability. So pay attention. That's a very good Nclex answer. Checking fetal heart rate and variability is a really great Nclex answer because that tells you how baby is doing. The provider performs an amniotomy to induce labor. Which of the following should the nurse monitor immediately after the procedure? So an amniotomy is where they break the obstetrician breaks the water. Okay, so there's on top of the baby's head is the amniotic sac can be broken and you can lose all the amniotic fluid, which can you imagine being the baby and like you're in a warm bath and then all of a sudden, what? It's all draining out. What's going on? I mean, you cannot possibly be happy about that. So anyway, an amniotomy is where they break the water intentionally. So what should you do next? What's the most important? Let's see, what does it say? What should the nurse monitor immediately? It doesn't say most important. It's really a first question. So what should they monitor first? You just broke the water. Maternal blood pressure, cervical dilation, contraction, intensity, or fetal heart rate. So y'all, I just told you that you do something to mom, you got to see how that affects baby. We just broke the water. We've got to see how that affected baby. So let's take a look at that. We can do the other things later, next after we check fetal heart rate. Okay. The nurse is caring for a client in labor when she notes that the umbilical cord has prolapsed. What is the priority action? All right. So this is one of the exceptions to what I just talked with you about. Prolapsed cord is when the umbilical cord falls out of the birth canal before the head of the baby. So it comes out before the head of the baby. What is the risk with prolapsed cord? Prolapsed umbilical cord. The risk is the baby's head is going to press on it. And you should assume, if they tell you there's prolapsed cord, you should assume baby's head is resting on it. You should assume that. Now, what's the risk with prolapsed cord? The risk is baby's head is going to rest on the cord and it's going to compress that cord. How is baby getting oxygen? Baby's getting oxygen through the cord. Okay, so we have got to get baby's head off the cord. How can we do that? Well, the more extreme way to do that is to physically, with 2 fingers, lift the baby's head off the cord. But that's not usually the answer I see on Nclex questions. What I usually see is repositioning, and repositioning involves through gravity getting mom's hips up so that baby's head falls back off the cord. So that's usually what I see. So, all right, so I haven't even read the answers yet. I'm just telling you what I'm thinking as I'm reading this question. So she's in labor. She's got a prolapsed cord. And I think, baby's head is on the cord. So what is the priority? If I can only do one thing, what one thing do I have to do? Continue to monitor fetal heart rate. Well, I definitely want to do that. I just told you that's really important. So I definitely want to monitor fetal heart rate. Reposition the client to relieve pressure on the cord. Well, I definitely want to do that. Increase the IV fluid. I want to do that. Prepare the client for immediate delivery. Not necessarily. That's not necessarily true. It may have to happen, but if I can get baby's head off the cord, we may not have to do that. So I'm going to have D be off. I'm crossing off D, and C, I want to do that, but I don't have to. If I can only do one thing, that's not the one thing I want to do. Okay. So I'm going to cross off C and D. So my concern is that baby's head is resting on the cord. So do I want to continue to monitor heart rate, but not reposition the client to relieve pressure on the cord? Or do I want to relieve pressure on the cord, but not continue to monitor fetal heart rate? Y'all, if I can only that's the problem with priority questions is there's usually 2 and you want to do them both. And what they want to know is, do you know what you have to do? Y'all, you have to get the baby's head off the cord. You have to. Do not say, well, I'm going to monitor because Dr. Sharon said monitoring fetal heart rate is a good answer. Okay, but when baby's head is pressing on the cord, you got to get the baby's head off the cord. Okay? Okay. After delivery, the nurse notes that the client's uterus is boggy, which means it's soft. So normally the uterus after delivery contracts and hardens. You should have a firm uterus after delivery. So after delivery, the nurse notes that the uterus is boggy and not contracting well. What condition does this suggest, and what is the primary risk? Uterine atony, and the risk is hemorrhage. Uterine inversion, and the risk is infection. Uterine prolapse, and the risk is pain. Or uterine rupture, and the risk is preeclampsia. So there's only one here that makes any sense at all, and that's uterine atony is the word used when the uterus is not contracting. That is what that word means. And the risk is hemorrhage. And I'll be honest with you, I'm not completely sure why the risk is hemorrhage, but I think there's something, because there's all these of mom's blood vessels that are going to the uterus, right? That's how babies get in blood, right? Because it goes through the placenta and through the umbilical cord, and so all this blood is going there. And I think what happens when the uterus contracts is I think it compresses all those blood vessels so they cannot hemorrhage. So I think what happens is that when it doesn't contract, those blood vessels stay sort of viable and open, and the risk is hemorrhage. That's a best guess. I didn't look that up, but I think that is probably right. Okay, so that, y'all, this is just a fundamentals of labor and delivery. This is not all you need to know for maternity. It's just a fundamentals of labor and delivery. It's an overview of labor and delivery. But if I had to say, if I could only know a few things, like I'm not a labor and delivery nurse, so I only know a few things, what I just talked with you about right now, you got to know it for Nclex, y'all. You got to know it for your standardized tests. Okay. All right. Good luck on everything, your tests and everything. Thank you for watching to the end of the video. I do appreciate it. Thank you for being a part of our Clinic Review family, and I'll see you later.